Appreciate you taking the time out to spend some time with us as we talk about what's happening with Kentucky Medicaid. We've got a great agenda. Next slide, please. Just to give you a little preview of what we're talking about today, we're going to be doing our usual update on renewals as we come through the public health emergency unwinding. Then we're going to shift over to the Medicaid reentry program, and Deputy Commissioner Leslie Hoffman's here to give us an update on what's going on with that. Erica Jones will be here to talk about school-based services, outreach, and education campaign that we are working on. And then today, one of the things we heard from folks is to just learn more about the department and the different divisions. So we're going to start a monthly division spotlight. And this month we have the Division for Health Plan Oversight with us. And then we're going to talk a little bit about an upcoming event we want to make sure you're aware of and extend an invitation to. So let's get started. Next slide, please. As folks may remember, next slide, please. As folks may remember, we are coming out of the public health emergency. We've been unwinding since March of 2023. States were required to go ahead and restart annual redeterminations or renewals. And so Kentucky started theirs with renewals May of 2023. We initiated those in April of 2023. And we've been working through the over 1 million individuals who had to go through a renewal over the past 12 months. Our unwinding kind of officially ended in May of 2024, although we had a few cases that went into June, but a very small number. And those, will continue to go through the process. So we're not completely done with the first round of renewals from the public health emergency unwinding. But as you can see, we're tracking this, and you can see kind of the natural decline that we anticipated as we started unwinding. We knew that we had folks that were remaining on the Medicaid program that were no longer eligible. And so as we've gone through those renewals, they have certainly dropped off, and we see that natural decline. Next slide, please. So as I mentioned, we started in May of 2023. Some of our PHE unwinding renewals have gone through June of 2024, but really that is the last of what we tied to the PHE unwinding renewals. And from there forward, we are gonna start reporting on just the regular renewals. We found that people were really interested in what's happening with renewals, and we want to continue that transparency and that reporting as we move out of unwinding. So now we're processing what we call non-PHE, non-public health emergency unwinding cases, just people going through their second renewal following the unwinding, as well as new folks who came into the program. We were still enrolling folks come April and May 2023. And so, for example, if someone entered Medicaid program for the first time in August of 2023, they're going through their first renewal this month. So that's still happening. But the good news is that the flexibilities we put into place for the public health emergency unwinding are still in place, and those are through June 2025. Those flexibilities help us in a variety of ways, including, helping folks navigate the renewal process. It gives us the ability to extend folks who haven't responded to a notice. We're allowed to extend everyone 1 month. And that means if they haven't responded by the time their renewal date approaches, and they can get an additional month. and we conduct outreach during that additional month to try to get them to respond. So 1 month for all folks. If you're long-term care or you're a 1915C waiver member, you can actually get up to 3 months. So all those extensions will continue through June of 2025. The other thing we track is a 90-day reconsideration period. So if someone does get terminated for lack of response, that's also called a procedural termination, then they have the ability, if they come back within 90 days following that termination and provide us the information that we need, and we can determine them eligible, they can be automatically reinstated, and they get that 90-day period back to their termination date reinstated as if there was no break in coverage. So that flexibility also continues through June of 2025, and we are encouraging folks that, you know, if you're in that 90-day period, to be sure to reach out, because you could still be reinstated. And we will also be continuing our CMS monthly reporting. This was started as part of unwinding. CMS wanted states to report on every month's renewal. So how many were terminated, how many were determined eligible, how many were actually renewed through what we call a passive renewal. That's where we go out and ping the trusted data sources. And if we're able to get information back to determine you eligible, there's no action taken on behalf of the individual. At that point, they just get automatically renewed. So those are that's information that we've been sharing with CMS. All of those reports are out on our website, so you can go out and look at them, as well as what we call an updated report that CMS started towards the end of last year. They wanted for states to report within that 90-day processing period following the month of renewal to see how many pending cases were processed. So if we go to the next slide, I can kind of walk through what I'm talking about. And it does look quite busy because we have a lot of months on there. We wanted to keep all the months on there so people could see them in one snapshot. But every month report is on our website if you wanted to look a little closer into any of these numbers. So let's take, for example, what you're looking at here is on the left-hand side is that original monthly report. That's where as soon as the month is over, by the 8th of the next month, we file a report with CMS to talk about the renewals that were processed. And so, for example, if we take March, we reported 97,962 individuals went through renewal. And of those, 7,358 were approved and 7,932 were terminated. At the end of March, we had 72 cases still pending. If someone is pending, that means their eligibility will continue until the state has taken action on whatever documentation was provided in support of that determination. So 72 cases in March were still pending, and so we had to report that. What you see in the middle there is that 90-day processing period I talked about. So CMS wanted us, if we processed any of those pending cases within the 90 days following the renewal month, we were to update the numbers accordingly. So on the right-hand side is the information from those updated reports. And let's take March again as an example. So we were able to process all 72 pending cases. And that means, as you can see, the approval numbers and the termination numbers have changed slightly as a result of that. So we had 6 folks that we were able to approve, and then the rest of the folks were terminated as part of that processing. So that's what you're seeing in these reports and the data on this slide. Let's go to the next slide, please. So on this slide, what we typically like to show is the more recent months. And part of that is because we are tracking that 90-day reinstatement period to see how many folks are being reinstated. And But before we get into that, let's take a look at the most recent numbers that we're reporting for the first time, and that is July. So in July, we had 40,719 individuals that were up for renewal. Of those, 36,036 were approved, 1,187 were terminated, and then I mentioned those two extension opportunities, 1 month for all folks, up to 3 months for long-term care and 1915C waiver members. They're in that extended bucket. That's different than pending. Pending means that we sent you a renewal and you responded and the state hadn't processed a renewal yet. Extended means you hadn't responded at all and you have the opportunity to be extended. So 3,496 individuals were extended from July. On the far right there, you'll see the reinstatements, that 90-day reinstatement period that we're following. And if you look back to April through August 12th, we had 4,340 folks actually be reinstated. In May, it's over 5,000, which is great. But we are tracking those, and that sort of helps us understand the churn as well between people who actually respond to a renewal notice and then gets terminated and comes back in. So closely tracking that information. Just as a reminder, all these reports are on our Unwinding website, so you can go out there and see more information. Next slide, please. All right, so I'm going to now turn it over to Deputy Commissioner Leslie Hoffman, who's going to give us an update on the reentry program.
Next slide, please. So good morning. I think last month in the forum, we spoke about reentry section 1115 demonstration being approved. So this month we wanted to share some additional information with you about what is an 1115, what does that mean? What does that mean for states? What does that mean for Kentucky? So I just wanted to go over those items with you. So an 1115 demonstration is often described as what we call a pilot project or a demonstration project. It's likely to assist or promote the objectives of the Medicaid program. Purposes for the demonstration are to give us more flexibility and to think outside the box, which is what we like to do in Kentucky most oftentimes, and design something that can really make a difference. So an 1115 project presents an opportunity for states to institute reforms that get us past just that regular routine medical care and focus on evidence-based interventions, maybe that other states are also working on too. We do share information and we want to better drive health outcomes and better quality of life. A demonstration, and you've heard us talk about this for many years, also must demonstrate what we call budget neutrality. And in a nutshell, that means that if we're going to think outside the box and we're going to be flexible and we're going to do something different, we're going to ask for CMS's approval to do that, we have to prove that we're not going to spend any more money than we already are. So it must be equal to or less than the current cost that we have when we're trying to promote this. So oftentimes it is hard. I'm just going to share that because we are held accountable for lots and lots of reporting because we have to show all along the way during a 5-year demonstration that we're doing that budget neutrality. So more so than any other program that I've worked in, we have to keep lots of reporting measures on a constant mechanism. I'm sorry, I'm seeing a question in the chat. I'm sorry. It said, if you have a question, put it in the chat. Apologize. Next slide. So Section 1115 requirements, like I said, we've got lots of things that go on related to requirements as a state. CMS, or the Center for Medicare and Medicaid Services, also give us an opportunity, usually through what we call an SMDL, which is a state Medicaid director's letter, and that kind of gives us guidance to know what's going to be expected of us, that if we want to go forth for this opportunity, what we need to do to make that happen, and then what we will need to do to continue that demonstration going forward. So we always wait for guidance. Full demonstrations that we have, like for example, our SUD, substance use disorder 1115, or our most recent reentry justice involved includes our our goals and objectives and milestones that we have to include for those demonstrations as well. Sorry, saying reentry and recent at the same time caught me there. As far as submitting requests, there's a whole process that we go through with CMS. So prior to submitting an application to CMS, states will conduct all kinds of stakeholder engagement. We want to learn from the stakeholders about the needs of the demonstration population. We have to figure out what gaps that we might have here in Kentucky and what barriers we might have here in Kentucky, and then what best practices are. So again, we often depend on other states that may be a little bit ahead of us, and they depend on us. If we're ahead of them, they depend on us. So we do try to, lessons learned are very important across the states. States also have to conduct research to learn what other states are doing to help guide them in best practices. States will then draft an application. Again, we go back and say we're going to do another public forum to inform the public and the state's intent to request the demonstration and discuss the program design. States may then revise the application that we have sent to CMS based on public comment that we receive from our Kentucky folks, our advocates, our members, our families, prior to resubmitting back to CMS again. So there's lots that go into an 1115. It's not as simple as just saying, oh, I just want 1115. We've got a lot of safeguards, and so do CMS. Next slide, please. So this is some activities that I wanted to make you aware of. For example, we had 9 small group interviews, 2 focus group, 2 public town halls. So Kentucky led lots of stakeholder engagement in the fall of 2023 for reentry prior to submitting that CMS application. Small interviews were performed with state agencies to gather information about agencies that relate to the justice-involved population. So remember that our sister agencies, the Department of Corrections and the Department of DJJ, is outside of our cabinet. So this has been a wonderful opportunity for us to integrate, get to know each other, and get to know about each other's programs and how we can work together to better Kentucky, to better the lives of all of our Kentuckians. Focus groups were also conducted with advocates, community providers, and we also include individuals with lived experience to help identify needs, barriers, and strengths. DMS also conducted virtual town halls to review the drafted application and to inform the public of the state's intent to request the demonstration. So CMS requires us to be very transparent, very out there with Kentucky, focus groups, town halls. We even had smaller work groups based off of our larger work group committees, and I'll explain a little bit more about that in the next slides to come. Next slide, please. So kind of this is our 4-pronged approach, but the most important thing is some of the things I've already said to you. So based on that state Medicaid director letter that we did not receive until March of last year, based on conversations that we've been having ongoing with CMS since 2020, I believe, and feedback from other states. These are things that we have to do as Kentucky. We have to ensure that the application is aligned with the CMS guidance that came out in I believe it was March or April of 2023. We have to ensure the state did not limit services to a certain number of Medicaid members, which we want to serve. And we had to narrow the covered service setting and the benefit package to ensure correctional facilities are able to meet what we call, or CMS calls, readiness. So just because you say that we want this in Kentucky and that we're ready to go forward, CMS expects you to do a readiness to really kind of prove to them that you're ready. And when you roll this out, you need to be ready to go. So there's a readiness, and we have to make sure that we have access to cover all the services in the demonstration. So what we tried to compile and put together in this application were things that we knew that we could do quickly, the things that we knew that we could build upon, and then things that we knew that we could roll out without. It's still going to be an effort. Can I tell you, this is going to be a big effort, but we wanted to make sure that we could meet that compliance for CMS. We also submitted a justification to allow for more than 30 days of pre-release coverage. It was 60 days. If you all have heard folks talk about that, CMS said, we're not going to give you more than 30. And if we do give you more than 30, you have to be able to justify. And based on our earlier conversations with CMS, we felt like we could justify 60. That doesn't mean that we might not change it in the future, but we had to have a baseline to get started with CMS so that we can build upon an approval. Next slide, please. So these are post-demonstration submission deliverables. So these are things that after you submit the application, these are additional things that we have to do for an 1115 that's a little bit different than our other programs. Plus, reentry has some very specific things. CMS knows we're working outside of our cabinet for most states. They know that we're working with sister agencies that don't sit side by side with us every day. So there was a couple of additional things that we had to figure out. And we know, and they knew, and we know that CMS doesn't normally cover services within those settings. So they knew that we would need additional items such as the reinvestment plan to work forward. So following the submission in December the 20th of 2023, CMS then conducted with our application a federal public comment of what we were requesting, not just a state public comment. And this began our negotiations back and forth with CMS under what they were calling a newly expedited approval approach. And I know that doesn't mean a whole lot to you all, other than at this point in time, they had so many states that were ready to go. They had to figure out a way to roll these out in phases. So Kentucky was approved on July the 2nd of 2024, and we were approved with 6 other cohorts or 6 other states in a cohort in what they called a bundle approval. So they were trying to get these 6 states in this cohort to all have kind of pretty much standardized terms and conditions across with their request. The states were approved based on when they applied, whether the reentry request was a part of an extension or if it was brand new in Kentucky, like it was brand new in Kentucky, and when states were currently have their demonstration set to expire. So if you've heard us talk about our big umbrella, we have our Big Team Kentucky umbrella, and we have all these components under our Big Team Kentucky umbrella. So this is one new component that we're going to have, which is reentry. Following that approval, states are required to submit implementation plans for CMS within 120 days. So we got approval on 7/2/24, and we've got 120 days to develop an implementation plan. So even after the implementation plan is approved, we've still got things to do. We are also working simultaneously on a reinvestment plan, a monitoring protocol, and within 150 days, and then an evaluation plan that has to be done within 180. So even though we can work on these things simultaneously, it's really about getting that implementation plan approved. Okay, next slide, please. Okay, this is just to go over a little bit. Move my screen just a second. This is really to go over just a little bit about our reentry target population and what that benefit package looks like. For the current request from CMS, it looks similar for the adults and the juveniles. So for enrollment and suspension on both, we initiate Medicaid application process for incarcerated individuals or confined youth. We begin no later than 60 days before their expected release date. Once enrolled, we suspend, we do not terminate eligibility. So those are very similar on the adult and the juvenile side. We have requested a 60-day, not a 30. We've asked for 60 days pre-release services. That means 60 days prior release, we can initiate services, get them connected with the MCO of their choice. And that is both the same on the adult side as well as the juvenile side. Pre-release services facilitations include 14 state prisons to get started. And then on our juveniles, that will be the DJJ Youth Development Centers, which means youth adjudicated and committed to DJJ custody, which we will currently and plan to work on more with the juvenile side as we have the Consolidated Appropriations Act that's come out, and then additional guidance that recently come out related to the CAA. And then we'll have to probably also submit state plan amendments to go along with what we're working on here. The benefit and service package is both case management. That's intensive case management, medication assisted treatment or MAT, which requires an SUD diagnosis, and a 30-day supply of medication. This 30-day supply of medication includes both physical and behavioral health needs. The service delivery can include in-person and telehealth options. Just as a reminder, individuals will not have the benefit of a full Medicaid package of services prior to release. It is still narrowed down to a specific package. This will allow, and then this approval that we are receiving, even though that we would want to look in the future at expanding, this will allow Kentucky to build upon the existing infrastructure to ensure a solid building block to support any future amendments, which may include additional settings. We are also right now in the works of discussing jails as a specific location in the future. Next slide, please. So this is something we're very proud of, and CMS has been very happy with this and has used this as an example. We developed the reentry program governance and project oversight. This is to ensure successful planning and implementation. Kentucky has implemented the structure to support project development and oversight, and that other folks can also have a voice at the table. It's not just DMS making decisions. Kentucky ACRES stands for Kentucky's Advisory and Community Collaboration for Reentry Services. That is our acronym, and we will provide strategic direction for the project team. The core team will support policy development and focus on implementation tasks and overseeing the work groups and or work streams, and I'll go over that a little bit later in our slides. The work streams are comprised of subject matter experts to focus on specific operational areas of the demonstration, such as operations, fiscal management, metrics, and monitoring. So we're very proud of our Kentucky ACRES, and as you can see, it includes Department of Medicaid, Department of Corrections, Department of Juvenile Justice, our MCO partners, other state agency partners, and then you'll have the work streams, and then that'll go on over to DMS's project team, which will maintain authority to provide oversight of all activities. Next slide, please. Okay. This is the work group participation that we currently have. I thought you might be interested in that. And that is a rather lengthy group that we have got involved into this Kentucky implementation. It's just not about Medicaid. It's a Kentucky implementation. ACRES includes representatives from across the state, as you can see, advisory committees, advocates, community organizations, and individuals with lived experience. Next slide, please. And this was just to give you an idea of our oversight and work streams that will support the project design. So not only do we have our core team that is interagency, we also have work streams that will also include other partners that have to do like specific tasks. Like we'll have individual work streams for things like operations, provider enrollment, workforce staff and capacity, communications, technology. I know this is a lot. The readiness assessment, training, metrics. There's a lot of things, the cross-functional reporting that we'll have to all do together to ensure that Kentucky's implementation can move forward. Next slide, please. And that's it. This is our DMS homepage, and this is our DMS issues. Feel free to reach out to us, and everybody knows that I usually say if you need to contact me via email, feel free to do so. We do have the DMS issues. Just label it that you've got a reentry question, and we would be happy to get that back to you. We have subject matter experts that pick those up out of the email box on a regular basis during the day. So thank you so much for having me.
Thanks, Leslie. There was just one question. Just want to make sure it got responded to. What does ACRES stand for? Could you remind folks what the acronym means? Because we do love our acronyms in Medicaid.
Sorry, I muted myself. It's Kentucky ACRES is the Advisory and Community Collaboration for Reentry Services. And yes, we love our acronyms, don't we?
Thank you. And just a reminder to folks, we do post these, there's a recording, and then we'll post the PowerPoint slides on our webpage as soon as within, a reasonable amount of time following the meeting, generally the next day. So certainly know that you'll have access to these as well. Okay, let's go to the next slide. So now we're going to shift to school-based services, and I'm going to ask Erica Jones, who is the branch manager for maternal and child health, and under the Division of Healthcare Policy. And Erica, I'll let you take it from here.
Great, thank you. Good morning, everyone. If you want to go ahead and go to the next slide. Kentucky Medicaid is launching an ad campaign this fall. It's intended to support health services in the school setting. It is a multimedia campaign and will run for several months and target specific zip codes in Jefferson County. Those zip codes were selected based on various factors, including high or chronic absenteeism and transportation or access to care issues. The goal of the ad campaign is to raise awareness among students, parents, caregivers, community providers, and school personnel, including the decision and policymakers. Since school-based service or school-based health services were expanded in 2019 to include all Medicaid enrolled children, not just those who have an individualized education plan, our goal is to help schools take advantage of this funding stream and offer services to more children who might not be able to access health care, including behavioral health care and other settings. Next slide. As mentioned earlier, this campaign is targeted and will focus on zip codes with high rates of school absenteeism within the Jefferson County public school system. Okay, next slide. This project feels like it's been a very long time in the making. I think that's because we are just really eager to get this rolled out and see the potential impact on children's health. Through the spring and summer, we've worked with our partners to determine which schools have already identified needs, as well as the capacity to increase delivery of services. And we anticipate learning from the project which outreach methods were successful and had the most impact in order to eventually replicate the successes across Kentucky. Next slide. This will be a multimedia campaign. So if you live in Jefferson County, you may see the campaign on TV, print, signage, or digital ads. And just a note, the media placements have not been completed just yet and are subject to change. Next slide. This has indeed been a partnership with various agencies. We are working collaboratively with the Louisville-based ad agency, Doe Anderson, our Cabinet for Health and Family Services leadership team, Department of Education, the Lieutenant Governor's Office, as well as Jefferson County Public Schools and Louisville Metro Public Health and Wellness, to ensure the campaign is taking the right approach and will yield the desired results. And we will continue to share updates and materials from the campaign as we move along through the process. And I'm not sure how we do questions, if you want to do those now or add those into the chat, but thank you for your time this morning.
Thank you, Erica. I'm not seeing any right now, but certainly everyone will be hanging out and can answer questions as they get posted. So we'll go ahead and move on. And if there are questions around the campaign, we'll certainly come back. So now shifting to our division spotlight, as I mentioned today, is going to be about the Division for Health Plan Oversight. I think people don't understand exactly how broad that is, the work that they do. And so we're happy to have Jeremy Armstrong DeRosset and David Very, who are both assistant directors under the division, and will be walking through the work that they do. So I am going to turn it over to Jeremy.
All right, thank you and good morning. Go ahead and change to the next slide. And as our Senior Deputy Commissioner, Veronica Judy Cecil mentioned, I am one of the Assistant Directors for the Division of Health Plan Oversight. Go ahead, next slide. I'm going to walk us through the first branch, which is the Appeals and Complaints branch. And this slide is just an introduction. So you'll see the branch manager, who is Stephanie Hodges, and the team under her. Next slide. So what does the Appeals and Complaints branch do? So the Appeals and Complaints branch does play a vital role for the Division of Health Plan Oversight. And what this team does is facilitates the external independent third-party review and administrative hearing process for the department. This branch will review the EITPR appeals request from the provider networks. When a provider is able to request an external independent third-party review is based on that first level appeal decision that has been rendered by our managed care partners. So when you have a claim or an adverse benefit final decision that is to a provider that is a denial in whole or in part of a Medicaid covered service, and it is not agreed upon, the provider has the opportunity to come to the department and request an external independent third-party review. The department does have requirements per the regulation that deems an external independent third-party review eligible to be reviewed by our contracted vendor, IPRO. IPRO stands for Island Peer Review Organization, and the Island Peer Review Organization entity will review the first level appeal decision made by our managed care partners and render a decision of either to uphold that MCO denial or overturn that MCO's decision. And so they can overturn that decision either in whole or in part. Let's go ahead and move on to the next slide. So the beginning of this first year in the first quarter, we've had some projects and initiatives that we have taken upon ourselves to really operationalize and streamline this process. So on this slide, you will see some of those steps that our team has taken by revamping some of the EITPR information sheet. And part of that information sheet does have a new requirement that attestation by our managed care partners to the accuracy and completion of all documentation. We've also taken an opportunity to streamline naming conventions to ensure that we have all our MCO partners uniform in those naming conventions. We have also started holding our quarterly MCO meetings that began this just a few months ago, and really just to improve the communication and relationship between the branch and our MCO partners. We've also taken the opportunity to provide our MCOs some additional assistance when access more so into our partner portal provider directory to also improve that information being received by our managed care partners. We do have an established email box where providers can submit requests for any updates. Before to start for a provider to request an external independent third-party review, regulation does require that they submit those requests directly to that MCO. This SB20 provider inbox is a collaboration. We've had an opportunity to work with one of our hospitals in our state, Baptist Health, and creating a spreadsheet for the provider appeal status inquiries. And we've been able to operationalize this and also offer this among other provider partners beginning on August 1st of this year. We've also continued to improve this EITPR submissions on our MCO's front end. So something that you can expect to receive in our provider networks is a network notification. So it's kind of going to be like an educational material and a new intake form. Next slide, please. So this first quarter is just, this first slide here is just to show you our first quarter iPro submissions, and a nice little pie chart or a graph here that shows how many total appeals that were completed, which was a very low number for that first quarter. And the reason being is from that previous slide where we were showing how we have been working together in collaboration with our provider networks, our MCO partners, to really streamline this process and really have an overhaul for this program. Next slide. Okay, the next slide you'll see in our second quarter, where you'll see in that very first top number that the appeals that were completed is night and day between the first quarter and second quarter. So appeals completed for the month in the second quarter so far is 649. Of those, our administrative cases were 505. Our iPro entity upheld 330 of those cases, partially overturned 29. And specifically, the medical necessity criteria of cases was 144. Our overturned cases was 287. We do track and monitor our pro entities requirement to render and review a decision within that 30 days. So we do track the decisions made within that 30 days. And for that second quarter, I apologize, the numbers hit at 552, and the cases that were rendered over 30 days was at 97. Next slide. So moving on to our next branch is our contract monitoring branch. Our contract monitoring branch really plays a vital role for the Department of Medicaid Services. And on this slide is just to show you an introduction to the team members and staffing within this team. Chelsea Agee is the program branch manager, and under her, she has several staffing. And as you can see, the positions are all of Medicaid, Medicare Service Specialist 3s. We've done some changes within this team to specifically identify liaisons. So that way, one staffing works directly with that managed care partner. And that's who those branch staffings are, and the liaison assigned to them next to that. Next slide, please. So really, contract monitoring branch really has an opportunity to be a part of and be included in everything involved with Medicaid and our managed care entities. The contract compliance branch does provide oversight to ensure that the managed care organizations that are contracted with the Department for Medicaid Services are compliant in all aspects to consistently provide reliable health care to the Kentucky's Medicaid managed care members. Our staff liaisons between MCOs and DMS as the point of contact and coordinating communications and connecting subject matter experts. We also partner with our sister agencies like the Department for Behavioral Health, our Department for Community-Based Services, our Department for Public Health on any related managed care issues and providing oversight of that consistency in contractual activities. Next slide, please. So this next slide is just an overview, a high-level overview of some of those things that we do within that CMB team. And so specifically in reviewing and assessing the encounter reports and the accuracy in imposing late fees and capitation withholdings when those records are non-compliant. So when we say encounters simply just truly means a claim. A claim is giving, the provider submits the claim for adjudication. Our MCO partner shares that claim adjudication information in an encounter format to the department. And the way we actually hold compliance to our MCO partners is we can issue an inquiry to our MCO, we can issue a letter of concern, or depending on the level of severity, we can go directly to a corrective action plan when those activities that are played in with our MCO partners are found to be deficient. This team will also review and approve corrective action plans when the MCO activities are found to be substantially non-compliant with any material provisions of our contract, such as breaches of member personal health information. We also require MCO partners to submit all provider and member materials in advance before disseminating into their provider networks or member networks. So we do approve and review all marketing and outreach documents for the Medicaid managed care members. We also attend community events to ensure that the MCOs are adhering to all marketing materials, distribution, and compliance with their contract. We do facilitate the MCO encounter file submission and resubmission in conjunction with the Office of Administrative and Technology Services and our HP partner. We conduct MCO provider network adequacy reviews. We maintain the MCO contact directories. We conduct on-site visits and off-site contract compliance audits. We facilitate a monthly MCO operations meeting. And we also assist colleagues in MCO contractual obligations specifically required for program and project activities. We monitor monthly, quarterly, and annual MCO reports. Go ahead to our next slide. And that's just a very high level overview of specific things that the MCO contract monitoring branch provides oversight for. Current initiatives that we are working towards this year. So the contract monitoring branch is currently working on a contract amendment for the 2025 managed care organizations. We have awarded our vendor Myers and Stauffer to help us procure and assist the contract review and development. We have already begun our weekly meetings with Myers and Stauffer, and we also include our DMS subject matter experts. And we don't always use just the DMS subject matter experts, but we also outreach to our sister agencies, provider networks, to aid us in that review and contractual changes and amendments that are future coming. Next slide. Oh, that's actually the end of my presentation. So thank you, Senior Deputy Commissioner, and I'll turn it back over to you.
I think actually I'll steal the deal. Good morning, everyone. I'm David Berry, and I'm the other Assistant Director in HIPPO, what we call ourselves in Health and Oversight. And I have two areas. One is eligibility and enrollment, and I believe Jordan Griffin is here.
I am here.
He's our intrepid branch manager, and I never like taking credit for other people's work. I'm going to embarrass her. Eligibility and enrollment is a vital part of the entire department. She keeps us on our toes. She gives us the information we need, and we'd be lost without her. So with that, Jordan.
Hi, I'm Jordan Griffin. I'm the eligibility and enrollment branch manager. This first slide is just, my name and then my staff who are really important to the work that we do. They kind of manage the ship while I'm away or while I'm in meetings. So I wouldn't be anything without the team. So you can go ahead and go to the next slide. So kind of a general overview of what we do in the eligibility and enrollment branch is we manage and provide oversight of Medicaid eligibility and enrollment policy and processes. So our branch, we're responsible for updates to the MMIS system, which is the Medicaid Management Information System. We also provide assistance with issues of eligibility in our IEES system, which is where Medicaid and other benefits eligibility is determined. And then we also ensure overall compliance with any Kentucky revised statutes, federal regulations, and the Medicaid state plan. You can go ahead. So one of our main initiatives right now and what we've been working on the most is eligibility for our justice involved population. So Deputy Commissioner earlier was talking about our 1115 waiver. So part of that is the eligibility portion where we have to monitor and update incarceration suspensions. So why we have to do that, just kind of a general overview of why we do that. There's an inmate exclusion in federal regulation that limits Medicaid coverage for individuals who are incarcerated. And so Medicaid will not generally cover healthcare services for these individuals who are incarcerated. And it applies to people in jails, prisons, or other correctional facilities. And we utilize a suspension process where we can maintain their Medicaid eligibility while their benefits remain in that suspended status. So they're not required to reapply during their reentry into the community. Part of that limitation, though, gives exception to emergency medical services. And so if an inmate needs emergency medical care, we can cover these services if they are in an inpatient setting for 24 hours or more. And so the reentry program aims to kind of bridge the gap between the incarceration period and their reentry period into the community, where there's going to be planning for continuity of care. And like that was mentioned earlier, we're expanding this program with the approval of our new 1115 reentry waiver. And so part of my branch's main goal is to streamline that process of the suspension, unsuspension, or issuing the emergency medical care services timely and making sure they have immediate access to their services upon release, and so that our providers can bill for services appropriately. And you can go forward. And so, what we've been doing as far as the actions we've been taking, we've requested feedback and cooperation from our managed care organizations, from the Department of Corrections, from our jails and providers. We hold ongoing meetings with providers, MCOs, and DOC staff to discuss pain points and where additional education or guidance may be needed. We currently mostly rely on automated systems and member reporting for incarceration suspension updates. So we're always looking for other ways that we can obtain that information timely and make sure that it's a reliable data source. So we've kind of opened it to where our providers can reach out to us directly to our branch if they notice that a member may be needing services and they may have a suspension on their account, but they're seeing them in person without police presence, right? So we've created a process and procedure where they can report this information to us directly, utilizing what's called the MAP Inc. It's an incarceration correction form. And so they can fill out that form, have the member sign it, attesting that they are not currently incarcerated, and we can go in and make those updates immediately in our system. Part of this process is going to also be creating additional training and education materials, just so that the jails, Department of Corrections, and our providers know the process we have to go through and can hopefully help them navigate that a little bit better. And so this is just one facet of what we do. There's many, many other things that we do related to eligibility and enrollment, but this is one of the main ones we've been working on. Next slide, please. And so some of the successes with what we've been doing, like I said, providers can resolve billing and eligibility issues by contacting us directly. It's created an increased communication loop between us, the MCOs, our sister agencies, members, and providers. It's created an open dialogue for what's working, what's not, what other steps we can take to make this process better for our members and stakeholders. And on the right-hand side here, you'll see kind of just a simple graph, but it shows a steady decline in the number of eligibility corrections that we've received based on quarterly counts. So, and what we would consider like a correction to eligibility would be something outside of kind of that 3-month period of change. And so, we've been correcting things further back than 3 months ago, or reviewing claims from, in the past. And so we see that each quarter we're slowly decreasing in the number of those types of corrections, which is great to see. That means that our communication and outreach is working. But we're always looking for better ways to make this policy more efficient and less burdensome for our members and providers. And that's all I have, David. Thank you.
Thank you, Jordan. Next slide, please. The other part of my responsibilities here is the KHBE, the Kentucky Health Benefit Exchange. Here's the team. We're pretty circular in our approach, but this is everyone who's helping me out. And next slide, please. We're the state-based marketplace for ACA plans, the Kentucky version of healthcare.gov, where we help residents of the state enroll in the best health coverage that they can get according to their circumstance. Because we're fully integrated, the system will figure out whether people qualify for Medicaid. And if they do not, they could qualify for financial assistance to help purchase a qualified health plan on the marketplace. We also train and oversee and support connectors. These are people who are out in the community. Sometimes they're in a hospital setting or other type situations. Sometimes they're out in community-based organizations, helping people find enrollment, find the healthcare solution that's the best for them. And we have licensed insurance agents, over 1,000 of them as well, who have signed up to help find people who need health coverage and get them signed up. We also certify that every plan that's offered on the marketplace meets the stringent requirements of the Affordable Care Act. And we'll Next slide, please. Two current activities. Well, a lot of current activities are going on right now as the open enrollment approaches. Unlike Medicaid, there is an open enrollment for qualified health plans that happens every fall, and you have to have a qualifying life event to enroll outside of that. So it gets pretty busy in this time of year as we prepare for that. We do a lot of preparation work with refreshing materials for outreach. We meet with connectors and agents, especially with webinars and one-on-ones and those kinds of things, make sure we're all ready. And we're constantly refreshing our website that offers deeper dive topics and fact sheets on a whole host of health coverage related interests so that people can be more informed. We have a bunch of system changes and enhancements that are coming down the pike. A lot of it has to do with improving the interface when people are using that self-service portal to fill an application or using the shopping portal to find the plan that best fits them. Also improvements to correspondence and those kinds of things as well. We host work groups and various human-centered design activities to try to make sure that we're calibrating whatever we're improving to whatever is going to make the best end result for the end user, which are the people looking for health coverage. New policy changes are coming. Some of them are really exciting. Starting November 1, DACA recipients will be eligible to enroll in a qualified health plan with financial assistance. So while they will not be eligible for Medicaid still, they will be able to find coverage through the state-based marketplace. We're also going to be automatically bumping people from a bronze plan to a silver plan if it is in their economic best interest and they're just unaware. It'll only happen if there's going to be a no-cost option to them, but we will make sure they're in the richer plan if they happen to have selected a plan that is not the best for them. And starting January 1, pregnancy itself will be a special enrollment reason for a qualified health plan. And that can go retroactive to any time during the pregnant person's pregnancy. It was exciting. Next slide, please. I know we're running a little low on time. We have about 82,000 who are currently enrolled. And the great news, as of last night, we have 100,000 people who have enrolled in the QHP sometime this year. So that doesn't pick up all or even most of the people who we've lost from Medicaid, but it does pick up a bunch of people who are in some kind of life transition, either between jobs, they just moved, and that kind of thing. And there's always a churn as that then they find jobs and that offer insurance or move on to Medicare, possibly move to and from the Commonwealth. So this is really, really good news. Next slide. The initiative that's going on that is really exciting is a complete reimagining of how we do metrics from our connectors. Connectors are the 500 or so individuals who are out in the community helping find people who need health coverage. And to date, they've been turning in spreadsheets that we turn into another spreadsheet to kind of find out what
Oh, I believe David might have frozen, if it's not me, just to make sure. And we are right on a minute over. As David was explaining, there is a lot of metric reporting that's required that will be being able to track with our connectors, some of the enhancements that's coming with Connect. But since we are right a little over time, let's go ahead and move to the recovery event. And we just want to do one last bit of information for folks just to make you aware that every year there is a recovery celebration that happens, and we're a part of that along with a lot of other agencies, the governor's office, and we want to make sure you folks know about it. It is going to be September 16th from 10:30 to 2. and it is on the Capitol, State Capitol South lawn. So just hold your calendar for that. We'll be posting things on our social media. So definitely follow us if you don't already on one of our social media platforms, and you can get more information through that. We have, I think, tried to keep up with questions as they've come through the chat. And I believe we are I think we've been able to respond to all of them. So I think we'll just take this opportunity to, again, thank you for coming. We are always open to hearing if there are other topics you'd like us to present on in a month, and we'll do our best to try to accommodate that. So if you do have any ideas about topics you want to see, please email Beth Fisher. She's put her email address into the chat. It's beth.fisher@ky.gov. And so feel free to submit those ideas to us. Again, thank you very much for joining us, and we hope you have a wonderful rest of the day. Take care.